Today, we'll be talking about non-alcoholic fatty liver disease and focusing on the diagnosis of NAFLD. I have no conflicts of interest for this presentation. I'll take you through the outline. I'll define what is NAFLD, who's at risk for NAFLD, how do patients present, and then move to the diagnosis. NAFLD is defined as a clinical pathological condition characterized by fat accumulation, also known as steatosis, in the liver, occurring in individuals who consume little or no alcohol. Alcohol consumption should be at least 20 grams per day or less. Another way of defining this would be less than 2 drinks in men and less than 1 drink in women. These patients usually present with unexplained elevations of liver chemistry tests and or fatty infiltration that was seen on an imaging study. By definition, all other forms of chronic liver disease should be excluded. This is important because fatty liver has been seen in other liver diseases, especially chronic viral hepatitis, where it could play a role in disease progression. There's been a lot of debate about how prevalent NAFLD is in the U.S. And this depends on how you diagnose or define NAFLD. Based on the Dallas Heart Study, where they looked at individuals based on liver imaging and recognizing fatty liver, this study showed that the prevalence of fatty liver could be up to 30%. And most of these individuals, nearly 80%, did not exhibit aminotransferase elevations. In the NHANES study, they defined NAFLD based on abnormal aminotransferases with no other explainable etiology. And based on this, the general prevalence was about 5.5%. So based on these two large studies, we can say that the prevalence of NAFLD in the U.S. is anywhere between 5 to 30%. Even if we were to take the lower percent, that is 5%, the overall prevalence of NAFLD in the U.S. is at least 3 times as prevalent compared to another liver disease which we all worry about, and that is hepatitis C. NAFLD appears to be most common among Hispanics, followed by whites, and least common in blacks in the U.S. And this is despite the fact that blacks do have higher risk factors, which I will talk about at a later slide. The prevalence of fatty liver appears to be equal among both males and females, except in whites, where it appears to be more common among men compared to women. Now, what are the risk factors for NAFLD? The most common ones are the first 3, which is type 2 diabetes, dyslipidemia, especially triglyceridemia, and obesity. If you see a patient and they have features of metabolic syndrome, these patients are at the highest risk of having NAFLD. There have been other associations with NAFLD, and these include obstructive sleep apnea, polycystic ovary syndrome, hypothyroidism, all of which are not uncommonly seen in the general medicine clinics. And there are other special conditions associated with NAFLD as well that we should know about. Most commonly, some surgical procedures such as the jejunal-ileal bypass, which is not commonly done these days, and gastroplasty for morbid obesity. Additionally, certain drugs such as amiodarone, long-term use of glucocorticoids, tamoxifen, and methotrexate have been associated with development of fatty liver. This is a very important slide. When we think about NAFLD or non-alcoholic fatty liver disease, we should think about in 2 broad spectrums. On the left side is what we define as NAFLD, or non-alcoholic fatty liver. And these are patients who just have fat or steatosis in the liver with not much inflammatory activity. On the right, we see steatohepatitis, and these are the patients we refer to as having NASH, or non-alcoholic steatohepatitis. These patients, in addition to having steatosis, also have inflammation, ballooning of the hepatocytes, and variable degrees of fibrosis. And this is very important clinically because patients with NASH are those who will progress with time, develop more fibrosis, and ultimately develop cirrhosis. It's not uncommon that we see either the radiologists or other physicians referring to a patient as having NASH. It's very important to keep in mind that NASH is a histologic diagnosis and not a clinical diagnosis. So if you see a patient with abnormal liver enzymes and fatty liver on an imaging study, and if they're not heavy drinkers, we should define them as having NAFLD, but not NAFL or NASH, because we don't have histology at that time. This slide goes through the pathophysiology of NAFLD. One of the key components of NAFLD is the presence of insulin resistance, which drives the fat from the periphery into the liver. So you have a liver which is accumulating a lot of excess fatty acids. And these fatty acids undergo oxidative stress, and this leads to an inflammatory component, and these patients develop NASH. What determines the progression of NASH to cirrhosis is not entirely clear, but there is evidence to show that with increasing age and features of metabolic syndrome, specifically obesity and diabetes, may play a very significant role in this disease progression. Now, why is it important to know whether patients have either NAFL or NASH? In general, simple fatty liver, or NAFL, appears to be mostly benign. The progression to cirrhosis over time is very rare, whereas NASH is histologically progressive. The risk of cirrhosis is about 25% within the next 10 years after diagnosis. And cirrhosis due to NASH has now become the second leading cause of hepatocellular carcinoma, and more importantly is associated with increased liver-related mortality. There's been studies to show that patients with NASH, other than cardiovascular-related mortality, the second leading cause is liver-related mortality. Now I'll focus on the diagnosis of NAFLD. We can look at this in three broad views. One is clinical, radiological, and histological. As I mentioned earlier, these patients usually have unexplained elevations of liver chemistry tests and are noted to have a fatty infiltrate on imaging studies. Most patients are asymptomatic. Sometimes they may present with some right upper quadrant discomfort or fatigue, both of which are nonspecific. In terms of lab abnormalities, they tend to have mild, sometimes moderate elevations of serum ALT or AST. Another important feature is some of these patients can have elevated alkaline phosphatase. So when you see an elevated alkaline phosphatase, even if it's isolated, you should think about NAFLD in your differential diagnosis. Another important feature is that some of these patients can have serum autoantibodies, specifically antinuclear antibody or smooth muscle antibody, which can be positive in low to moderate titers. So if you have a patient with mild elevations of aminotransferases, a positive ANA, and a fatty liver on imaging, we should not be thinking about autoimmune hepatitis just because their ANA is positive. They most likely have NAFLD. On radiology, the most common test that we routinely do is an ultrasound, which shows a hyperechoic or a bright liver. It is about 85 to 95% sensitive and anywhere between 70 to 95% specific. CT, MR, and NMR spectroscopy are other modes that have been used. Specifically MR, which has the advantage of also quantifying the amount of fat in the liver. And this can be done with an MR without contrast. One important thing to keep in mind is that imaging studies cannot differentiate steatosis or simple steatosis or NAFLD from NASH, and they cannot assess the degree of fibrosis in most patients. Now, how do we assess the histologic severity in patients with NAFLD? Because this is clinically important for us to know. To date, liver biopsy still remains the gold standard. It is able to differentiate NAFLD versus NASH and also gives us a good extent of the severity in terms of fibrosis. Yes, there is sampling error, but it still remains the best test to date. There are several non-invasive methods, and you can broadly look at these into two categories. One is serum markers. These could be clinical and or biochemical, and imaging modalities. Among the serum biomarkers, there are a few which are important to note. One is the cytokeratin 18 fragment, which is not routinely available, but cytokeratin 18 fragment is important because it appears to reflect the degree of apoptosis or cell death, which is a characteristic feature of NASH. Some of the recent studies have shown that although specific, it appears to have limited sensitivity, specifically for NASH or fibrosis. So it's unclear what role CK18 measurements will have as part of routine screening. There is some evidence to show that it may be useful for surveillance in the long run as we are following these patients. There are several fibrosis markers or liver fibrosis panels, which you can see on the screen. Some of these are commercially available, even in the US. They're not routinely used, and it's unclear how useful they are clinically in terms of gauging the severity of disease in our patients in the US. One of the probably most commonly used, simple to use, and very useful tool in the office is a NAFLD fibrosis score. You can actually calculate this in the office when you're seeing the patient, and this uses simple variables like age, BMI, whether the patient has hyperglycemia, the platelet count, albumin, and the AST to ALT ratio. And then we have other non-invasive technologies using imaging, and one of the most important ones, which is not routinely available in the US, but it's used throughout the world, is what is known as transient elastography, most commonly using ultrasound technology. Now this slide shows the spectrum of fatty liver disease. You can have on one side a simple steatosis or NAFLD, where the major component of the histology is a lot of steatosis without much inflammatory component. On the other side is NASH. As I mentioned, in addition to the steatosis, you need to see other important histologic features, which include ballooning and inflammation, especially in the lobule. As I mentioned, patients with NASH have variable degrees of fibrosis, and these are the patients who ultimately can progress to cirrhosis. Currently, the most widely used NAFLD scoring system is what is known as the NASH Clinical Research Network scoring system. And this separates the histology broadly into the grade. The grade includes steatosis, the severity of steatosis, severity of lobular inflammation, and severity of hepatocyte ballooning. Together, they form what's known as the NASH activity score. And then you have the stage, which determines the severity of fibrosis. So the NASH activity score goes from 0 to 8, and the fibrosis from 0 to 4, and combined will give us a global NASH score 0 to 12. This is a very useful tool not only in assessing the severity of the fatty liver in our patients, but also if patients do get follow-up liver biopsies, it will help us determine the progression. I'll talk about the NAFLD fibrosis score. As I mentioned, these use simple variables, which you can get in the office. And there's a website for this, and you can put this on your phone as well. And once you get the value, you can broadly categorize the patients into 3 categories. The NAFLD score less than negative 1.455. These are patients who are more likely to have very mild disease. That is F0 to F2. So either no fibrosis or mild degree of fibrosis. And then patients who have a score greater than 0.675 are more likely to have F3 or F4, and that is bridging fibrosis or cirrhosis. Patients who have the values in between form in the indeterminate or what's called the gray area. These patients are very difficult to determine based on the NAFLD fibrosis score. So if we are interested in knowing how severe the disease is, these patients will require a liver biopsy. The NAFLD fibrosis score has been well validated in several populations. So it's again a very simple tool that we can use in the office. You can also use this to follow these patients over time. Next is the imaging techniques, which use the principle of elastography. Basically, elastography is a technique, it's a non-invasive way of measuring liver stiffness. What this does is it uses an ultrasound transducer probe, which is mounted to an axis of a vibrator. And this probe basically transmits vibrations of mild amplitude and low frequency. And pulse echo ultrasound acquisitions are used, which follow the propagation of the shear waves across the liver tissue. And basically, the velocity of these shear waves directly is related to the tissue stiffness. And so it's expressed in terms of kilopascals. So the more stiff the liver is, the slower the wave is. Now, one limitation of the earlier version of this is in the obese patients. So to counter that, there's a new probe called the XL probe, which has been designed specifically for obese patients. And this more accurately determines the liver stiffness and in turn gives us an idea of the liver fibrosis. This way of measuring liver stiffness has been well validated, and it seems to correlate quite nicely with fibrosis that has been seen on liver biopsies. Now, is there another way of looking at NAFLD severity based on the clinical features? This is a study from our group which has shown that if you see a patient in your clinic and they actually meet the criteria for metabolic syndrome, they're more likely to have NASH and also more likely to have bridging fibrosis and more disease severity. Since there are so many patients that we see in the clinic who have NAFLD, if you're trying to make a decision that who we should biopsy, again, a simple way of assessing these patients is to see if they actually meet criteria for metabolic syndrome. And if they do, you can be confident that they may have more severe liver disease, and in those patients, consider offering a liver biopsy. A very important aspect of NAFLD is that patients who have NAFLD appear to be independently at risk for cardiovascular disease as well. So NAFLD not only appears to be a biomarker, but an early mediator of atherosclerosis. And this has been based on several studies which have shown that patients with NAFLD have evidence of increased risk based on elevated levels of plasma biomarkers of inflammation, endothelial dysfunction, early carotid changes, and even early myocardial dysfunction. Also, there appears to be a graded relationship between the histologic severity of NAFLD and the degree of atherosclerosis. What is very important to note is that this increased cardiovascular risk is seen even after adjusting for the traditional risk factors and components of metabolic syndrome, which we all know are confer increased cardiovascular morbidity. So even when you control for these, the presence of NAFLD appears to increase that risk. This is very important clinically for us because when you see a patient with fatty liver, not only should we focus on managing the fatty liver, but also be aggressive in terms of managing their cardiovascular risk factors as well. Pediatric NAFLD appears to be the most common cause of chronic liver disease in the pre-adolescent and adolescent age groups in most of the Western world, including the U.S. Up to 10% of the American population aged 2 to 19 years have NAFLD. About 40% of those who are obese. Children may also develop end-stage liver disease requiring need for liver transplantation. To summarize, NAFLD is one of the most common causes of chronic liver disease. It's also a common cause of cirrhosis and hepatocellular carcinoma. Insulin resistance is a key component of NAFLD. The presence of metabolic syndrome increases the risk of disease progression. So identifying these patients in our clinics is very important. Also important is the fact that NAFLD can increase cardiovascular morbidity. The diagnosis of fatty liver can be made by clinical and radiological methods. However, to date, liver biopsy remains the gold standard for assessing histologic spectrum and severity. Since we see a lot of patients, a decision about liver biopsy can be based on the presence of risk factors for more disease progression, and that will include patients with metabolic syndrome. Several non-invasive methods of determining liver disease severity are currently available and are being refined continuously. Of these, the most common tool, which I think can be useful, is the NAFLD fibrosis score. Thank you.